No, I'm good. That'll raise some suspicions.
Oh, you talking about? Not like that.
Where we even at? About that. I got the extra one at the house, cause I got the new one. Both came the same day. I was like, I'm just gonna take both. We'll take two.
Oh, nice. Good. Look at you. Let me see your. Always like to see. I gotta get one of those Raptor trauma shoes,
Yeah,
man.
mine's coming today.
Is it? I gotta get one of those.
Oh wow, you got a whole.
Oh, you got the blood pressure.
Dang.
Wow.
Okay, see, that's a little bit
Yeah,
better.
see,
I just got
yeah, my Raptor comes.
I got two.
I'm so
I got-
excited.
I know, cause I mean,
I got 2 stethoscopes because they forgot to send it to me on time.
are you kidding me?
No, because this is what happened. I asked for a stethoscope. I ordered it, paid for it and everything. It was supposed to be here like 3 weeks. Like 3 weeks after it came late.
Dude.
And then I'm like, yo, at first it didn't come at all. So I was like, I didn't get it. We'll send you a new one. It's coming in on this day. I said, cool. I opened the door. I checked my mail.
There's
both,
2 of them.
and there was like, well, I'm not going to go through the trouble of trying to send it back. Maybe I'll just keep it for
Yeah,
another 3 weeks.
what stethoscope did you order?
Some nonsense, well, nothing nice.
Look at your nonsense. Oh, it's a Littman.
Oh, it is?
It's a type of Littman, yeah. But
Oh.
that'll work. Yep. Mm-hmm.
Well, I got 2 of them.
Well, cool. Okay, so remember, if you hear the door jiggle, y'all need to spread. Scatter.
Well, separate.
But like I said, you can take that mannequin off the table and set and kind of spread a little bit. So again, we try to do our part.
You just want to pick them up.
I appreciate picking them up last time.
Yeah, I said, you see right here, so you see.
It's so awkward.
Yeah, stick him in the corner. That's pretty cool. Okay, so we're waiting on Joseph to get back, so.
Yeah, I had never seen eyes dilate, so I did it. Like, my little sister came up here, and I did it to my little sister.
Yeah, so practice. That's what you're, listen to your little sister with your stethoscope. Because again, the more time that you train your ears now, the better. Especially when you're doing clinicals and you're bouncing around in the back of the truck. It'll help, trust me.
Order your pen light too. I'll take you, man. That big like $20 a day. Glucose check is for free, right?
Yes. I could put system, glucose system, whatever you call it, we call it active check, glucose check, so that you're all tracking. Hold tight.
They still take it fast.
He's not in there.
No, no, oh, yeah, yeah.
He's in the medical field already.
Yeah. He wants to do something better with his life. He wants to. God knows.
What is he doing?
Nah, he look like a medical assistant. Like that.
I'd love to get him in the Discord, because if he's got more current knowledge.
I gave him the link. I gave him the link to it, yeah, because we talked about it. The day he took the chapter 7 test, I sent him a text message.
I don't even see his name on the side. Checking on Discord membership.
His membership.
Did you pay your dues?
We still gotta have a Ring of Fire Death match to let you into the class. One of us has to go for you to get here.
We already made a deal.
Wait, Ryan, who is it?
Yeah, no, we made
Wait, what? Hold on.
If she wants to stay in our class, she gotta, if we hit the wall, she gotta get the candy bar.
Oh, she's gonna have You are our
covering
insurance
our,
policy.
Yeah, she's,
Right.
she's
Oh,
covering
speaking
us.
of which, who was me a candy bar for
That
last
was
week?
I.
Me.
It's
Me.
right
I
here.
was riding in the thing.
You were riding on the stretcher,
Yeah.
you're the one who got banged around, okay, we got you.
Disrespectful.
So she gets to cover her liability
She
insurance?
gotta pay her.
Exactly, for the liability insurance.
Yeah, she gotta pay her dues. So we
Alright,
should just beg
so-
it. Just.
So a couple of things let's kind of go over, because I'm kind of going in between your EMSP 1110 to 20. We're more so moving today in EMSP 1120 with your primary assessments and monitoring devices and things like that. We have somewhat gone over this already. I've told you this, I will tell you this till I'm blue in the face, is that the first 5 never change. There's only several exceptions when we talk about CPR and we talk about certain trauma cases. But these first 5 will never change when it comes to your primary assessment of a medical and or trauma patient. Again, your scene safety, you and your partner's scene safety will always come first above all else, okay? And again, I made the point of you and your partner are driving up to the scene of the accident or location of where the call is, and come here, Earl. And that bring your chair, and that begins inside the truck, okay? I can't explain it enough to you in detail, is that you or your partner, again, we're driving in the truck, and we're looking for any type of dangers that may be around. We're looking for scene safety from the safety of our truck. Remember that your truck is the most safest place for you, because that's your workspace. That is your, whatever you want to call it, okay? That's your workspace, that's your safe place. You know it quite well. You will know it well as far as all the equipment is concerned. So again, scene safety inside the truck as you're approaching the scene. If, for whatever reason, something is telling you something's not right, that little voice that you hear, the little hairs that stick on your head, your gut's telling you, just drive away from the location and call for public safety or the police department to come and secure your scene with you, okay? I'd rather you need them, I'd rather you call them and not need them than for you to need them and you've just got yourself in a heap of trouble, okay? That's one thing I cannot teach you in the field, is listening to that inner voice, okay? Now granted, you are with a partner, and again, you go in as a crew, you come out as a crew. You're never kind of left alone, except for that one instance in which you're in a hostage type situation and you or your partner can get out. It's just that they've taken a mental note of the actual location of where things are in the house and how it's laid out for the police department, so that once they barge in with the SWAT team or whatever they are choosing to do, they have that option. Because again, the moment that you clear the scene and you're entering someone's house, again, it is your responsibility to take a mental note of how things are laid out. What all is included within your exit plan should you have to egress very quickly. That means doors as well as windows. So you need to ensure that you know all of your exits when you are entering someone's house, because again, I'm asking you to go into unfamiliar territory. Someone's house, you have no clue who's in there. Now, again, the majority of the time, people are inviting you into their homes because they know that you're here to help. They are the ones who called. They want you to fix what's broken, or have a situation as total chaos and make some type of sense out of it and then take them to the hospital. That's not all the case, especially with what's going on in our world right now. The rioters that are going on, those that just, I don't know if y'all saw the 2 police officers that were shot point blank in the face in LA. But they had video of that where the guy just came right on the outside of their car and shot it multiple times. The driver got shot through the jaw. The other guy got shot, I think, in the arm or something like that, and he started running off. Well, the police officers put themselves in a building, and you see the police officer who was shot in the jaw putting a tourniquet on her partner. You just don't know what you're walking into, even in a staging area, okay? Now, at Grady, we were stationed at certain Atlanta Fire Department stations, but we also had those parking lots where we had to go and sit at, okay? So again, you're not guaranteed to be at a station, and even at a station is not safe anymore. So again, you have to mentally picture this with it, okay? So scene safety is always going to come first. You and your partner is above anybody else's, okay? Then we move on, okay, we're taking all our equipment. As we're coming to the door, you always knock to the side of the door, never in front of the door, because you could get, okay, blown right through the door, okay, with a shotgun or any type of high-powered caliber pistol, gun, rifle, whatever, okay, you never stand in front of the door. Once you're invited in, then your primary assessment begins with number 2 coming down. As you're approaching the patient, again, this is what I've told you before. What is my patient telling me as I'm walking in and I'm laying my eyes on them? Are they giving me any indication that they're in distress? What are they telling you? We kind of went over that in the respiratory system a little bit when we're saying, okay, well, if someone's tripoding or if they're breathing 50 times a minute, you're going to kind of pick up on that, aren't you? That's how come we're using all of our senses, vision being one of them. We're going to confirm that with auscultation, putting our hands on our patient, palpating the patient, and things like this. So now we're at number 2. We're determining the general impression of our patient. Thanks, Harold. Okay, so general impression of the patient with a level of consciousness. And again, let me make the statement. The Glasgow Coma Scale, as well as AVPU, which is something else that you can use to determine a level of consciousness, this does not record cognitive function of memory and things that they should know. It's not saying you can't use it, but it's not something that's going to really give you that key indicator of level of consciousness. So when we talk about documentation of consciousness, okay, you always see either alert and oriented, or you'll see an A&O times 4, okay? I highly discourage this right here. If you have someone that is of not, what you call a normal capacity mental state, and that's not their standard, you cannot put this for that patient. If you're going to use that, that's fine, but just list what they're alert and oriented to. Now again, you have to use abbreviations that's across the medical board, across all of the fields. Sometimes this will apply and sometimes it will not. So again, if you're going to use it, then describe what they're alert and oriented to. Your book says to a person, right?
I got you.
Right? So describe that. Now, if you have a patient who's let's say mentally challenged, okay, let's say that their norm is to person who the president is and who their caretaker is, and that's their norm, then you need to document that followed by per the caretaker, per the healthcare provider, per a parent, per somebody who is with that patient every day. So that you are painting the picture that, yes, I determined their level of consciousness, and you verified it with someone who's with them every day. If this is the first person, or if this is the first time you're making contact with them, and you're going, wow, they don't know where they are, they don't know what the time is, you're going to say, well, they're altered. Well, no, they're not. You have to verify that through your documentation as well as your interview with healthcare providers and caretakers of that patient, that this is their norm. Okay? I'm not saying that you can't use it. Just be very careful if you're ever called into court. In order to eliminate that, then list it to person, place, time, and event. You ask them specific questions. Ma'am, you know where you are, you know what time it is, you know what day it is. Ask them other questions that they would know. Then you can document the fact that they're alert to person, place, time, and event. Why did you call? Why did you call 911? That's the event, correct? The time and date, the place. You picked them up at your home. You know where you are right now? Let me have your name, ma'am, sir. You feel where I'm going with this? This is all under level of consciousness, and this is as we're approaching the patient. It'll be confirmed once we start asking questions. Mechanism of injury. This deals with trauma. What type of force caused the injury? Some of it will be obvious, some of it will not. The nature of the illness, again, more toward medical issues. Again, there are certain things to determine the nature of the illness, just like mechanism, but let's talk for just a minute about medical stuff, because trauma comes later. So we have something that's called sample, and then we have something that's called OPQRST to begin that assessment. This is in your primary assessment chapter. Your sample, again, is an abbreviation for something that will help you kind of get your mind started on some of the questions you want to ask. Okay, this is symptoms. Oh, sorry. S stands for symptoms. Are they allergic to any medicines? What type of medications are they taking? Their past medical history. Okay? Last oral intake. Why is that important? Anybody want to take a guess?
You know what medicine they take, because that could, like, medicine has symptoms, so it could affect it how they got out.
Yeah, food, drink, okay? Part of the reason why we want to know that is, one, if they've taken all their medications and stuff like that, did they follow up with something to eat? And to notify the hospital should they have to go into surgery. Yeah, there's a lot of not so good stuff. If they've just eaten within the past half hour, they're not going to necessarily put them into surgery necessarily. Okay? So this is something that kind of jogs your memory into what type of questions we're trying to get at, which is none other than the chief complaint, or CC. The questions that you ask are going to be relevant to their chief complaint. I don't want to know about their past medical history that they had a toe replaced or operated on when they're having trouble breathing. That is not my concern. I don't care that they had, hair replacement 10 years ago. I don't care that they had an appendectomy 40 years ago. That is not relevant to the chief complaint. We want to know, is there anything related from your past medical history that could be causing your respiratory distress, we'll say? Signs and symptoms, or symptoms. Okay, they're going to tell you, well, I can't catch my breath. I have no relief from the medications that I'm taking. Okay, well, you're allergic to anything, for one. Okay, then now what type of medications are you taking? All of them. And then the past medical history is going to be relevant to the chief complaint. If someone's having respiratory distress, what are the two systems I want to know about, and what meds and what past medical history I need to know about? Respiratory and cardiovascular, because they work hand in hand. That's what I need to know. And then the answers to your questions are going to spark more questions, or at least they should. Now remember, this is all fine and dandy when you have someone that you can ask open-ended questions to. It's not the case when you're having to do a closed-ended questions on all the questions you now have to give. If there's certain things that you need to know, then you need to ask them specifically.
You have to know the stuff to ask, especially if it goes to, I'm gonna need to know if you have any respiratory or cardiac conditions, and you're gonna have to go through, because if they give you a yes, you're gonna, okay, ACS, you know, all of that.
Hypertension, asthma, COPD, emphysema,
Yeah.
ask specific
You wanna say
questions
something?
because this is going to be important. Okay, it's all relative to the chief complaint. Last oral intake, that's medication as well as food or drink, and then the events leading up to the situation of why they called. Now, part of the reason why this is important is that we need to know, were they at rest when this event happened, which makes it acute? Or were they actually exerting themselves when this thing happened in order for them to call 911?
Acute means severe, right?
Acute meaning suddenly, very quickly, all of a sudden.
I thought, yeah, I'm messing you up on that. I thought acute was possibly short-term but severe when like in relation to ACS, like acute coronary. So
No.
stop listening.
Acute, okay, you cannot put acute coronary syndrome in an acute versus a chronic disease process. Something's acute, rapid onset, sudden onset.
Rapid, so-
Chronic is more of a gradual time frame, like
Yeah.
COPD would be one. Congestive heart failure would be another. Whereas an acute situation would be an ACS or an AMI or stroke or something like that. Okay, so they're very different as far as that is concerned. Amon, I don't know what you're doing, hon, but you better get off that cell phone. Okay? So again, this is to kind of get you jump started in the type of questions you need to ask. Again, other questions should develop with the answers that your patient's telling you, right? Now, OPQRST is for something, it can be used for one or two different things, for pain or for a respiratory distress call.
What, I'm sorry, what is the last thing?
Nature of the illness. That's more medical. Mechanism of entry is more for trauma. Okay? Yep. So the number of patients, and again, additional resources. Do I have more than one patient? If so, then I need to call another unit. Do I need the fire department? Do I need the water department? Do I need the utility? Whatever. This is the additional resources that we're talking about. Anything that, do I need the police out here, whatever, because of crowd control or something? So additional resources. So OPQRST is more for, if you will, a pain, when someone complains of pain. So O stands for onset.
When did it start?
Onset. Was it sudden or was it a gradual process? P stands for provocation. Provocation? Is that right? Provocation?
Yeah.
Okay. Anything make it better or worse? R stands for radiation. Does the pain radiate anywhere? Because,
What about Q?
oh shoot. Sorry.
Q is silent, alright?
Like a K and I.
Sorry. Okay. Sorry. Q stands for quality.
Is that where you're rating it on the scale?
Yep, so this is the pain scale. Now, please be very mindful of your pain scale. I don't care which one you use, make sure that you understand the pain scale you are using. If you are using a 1 to 10 pain scale, that means 1 means they have 0 pain.
That is the worst pain you've ever felt.
Okay, 10 is the worst pain they've ever felt. A 0 to 10 means 0, 0.
Okay.
Understand your pain scale. This is very different.
Do they have a preference for taking this instrument?
This is all you as far as what pain scale you use. Now at the doctor's office, you know, they have the smiley face or the long
Yeah,
wire
they've got the whole
facial
chart.
stuff. Okay, okay, they go to 0 to 10 if I'm not mistaken.
Yeah.
So again, whatever pain scale you choose to use on your documentation, make sure that you understand what pain scale you're using. Because a lot of people's going to initiate, well, 1, they have a 1. Okay, well, we need to fix that. Because again, pain management is one of those those things that we do in the field. So again, whatever pain scale, make sure you understand what you're using. Okay, so the quality of the pain. Then R stands for radiation. Does the pain go anywhere? Now please be mindful that when someone has pain that radiates, that's one thing. So if I have pain in my chest and it radiates up to my jaw and to my left arm, that is one thing. But if I have pain in my chest and a pain in my butt, then those are two different pain things. One may be called deferred pain, which means that, okay, my gallbladder's hurting, but I have shoulder pain. This is what's called deferred pain because it follows the same route of innervation. Okay, so that's totally different. Okay, yeah. Okay, so one is deferred pain, one is radiate. Does it go anywhere? Does it move? Okay.
I'd be at the fire station or something.
I'm sorry, I missed this up, you guys. I'm sorry. Severity, severity is your pain scale. My bad, I'm so sorry. So quality is it sharp, dull, etc. I'm sorry. I'm so sorry about that. Sorry.
Okay, so quality is sharp, dull,
Sharp, dull. Does it feel like a stabbing pain? Is it a shearing pain? Kind of, it's like an adjective. You're trying to get them to describe it. The severity is the pain scale. My bad.
Patients will 9 times out of 10 give you a 10.
Oh
So
yeah.
not many out of 10.
Okay, so T stands for time. That is how long has this incident been going on? It's very different from the onset. You tracking?
What was onset again? What were you doing?
Is it chronic? Was it all of a sudden, or was it a gradual process? Because time's gonna kind of support the onset. So, well, it's been like a couple of hours. That's gonna kind of come back up to your onset. Was it acute? Was it all of a sudden, or was it like a gradual process? So, sample OP-Cure is T. And then your ABCs, in that order, you fix what you find. Go ahead.
And with those, we're looking at like the OP-QRST more for trauma patients and the sample history for analyzed medical
No.
conditions.
No.
Both, we're doing both?
Yeah.
Okay.
I can be a medical patient and have abdominal pain.
Yeah,
No trauma, just abdominal pain.
so we're gonna go through the whole series now.
Yep. Okay, so you have to look at that. Chest pain, toothache, pain. Any type of pain, it not necessarily have to be because of trauma. Okay. All right, so before we start playing and getting dirty, okay, so ABCs, airway. We need to ensure that it's open, clear, and patent. We do that by talking with the patient. Okay, we're listening for upper airway sounds. You should know those by now. They are Strider.
Crackles are usually
upper airway.
Oh,
upper airway strider.
Strider and snoring and crowing and gurgling.
I thought crowing was strider. Isn't
It's
strider
negative,
another
two different
name?
things.
Two different things.
Okay.
The sounds are different.
Okay.
Crowing sounds just like a crow.
And it happens in the vocal cord.
Right, which is the cutoff point from upper versus lower.
And that's pretty much probably just another occlusion. So strider and crowing would be occlusions of the upper airway, just different areas, or?
It's like they start doing like this.
It's not really,
Yeah.
it's not really an occlusion.
I'm gonna put that.
Okay,
on
so the strider and the strider and the crowing are sounds because there's an inflammation within the larynx or just higher.
Okay.
Okay, and you
Not
hear the
necessarily.
airflow flapping over the epiglottis is what you're hearing, as well as some of the edema portion. Okay. Now, again, airway's got to be open, patent, and clear. We determine that by, is the patient talking with me? Because if they're talking with me, then that means ventilation is occurring. Breathing comes next. I cannot stress this enough. The rate comes first. The rate, the quality, and the character, or I think your book says the rate, the rhythm, and the depth. There we go. Okay, so whatever you want to learn. Okay,
You're
title
saying
wise.
Despite having a good rate, even though we do that first, it doesn't necessarily mean it happened like after because you have shallow.
Correct.
Okay.
Correct. Okay. The rate needs to come first because this is what we're going to fix first. So if we feel, after we've made the determination of a proper assessment of breathing, they need oxygen, guess what? We're going to be applying oxygen right now before we continue. ABC's in that order except for CPR and other stuff. Again, breathing, these things have to be in place because if I don't have an airway, they're not going to be breathing, and eventually they're not going to have any circulation to go with that. This is why the hierarchy is here. ABCs in that order, fix what you find.
Okay, we got rate, rhythm, and then,
Yes, whatever
Quality.
ones
and what words did you use?
rate the quality and the character. Same thing with circulation. The rate comes first, the quality and the character, because if, for whatever reason, everybody wants to just jump to a blood pressure. Okay, that's
So you said they come as the rate.
quality and the character, just like breathing. Yes, okay. Now, under circulation also includes, as part of your primary assessment, is skin color, temp. We talked about that. We're not using, hey man, let me check, okay, it's not with the palm of our hand, it's always with the back of our hand. And we check core, not necessarily peripheral. This is important, yes, but we want to make sure, does this match this? Mind if I touch you? Or this, because this is core. If this is different and it's cooler than his core, then what does this tell me?
He's gonna have he's the blood.
He's starting to shun. That means he's going into shock. Okay, remember the definition of shock. Shock is very simple, 3 words. Inadequate tissue perfusion. Inadequate tissue perfusion.
I've been seeing it too, where they're doing the temp test on the abdomen. Is that gonna be just a preferential thing, whether it's chest or abdomen or?
Chest or abdomen, as long as it's a core part, yes, okay? Forehead may not always be the case because of the fact it's exposed to the elements like the arms are, but always chest or abdomen, that way, and again, it's always the back side of your hand, never the palm of your hand.
Inadequate?
Tissue perfusion.
That's chapter 8. And what is it associated with?
That's shock. That's the definition of shock. Okay, so again, I need to know if he is starting to shine, because that tells me something else is going on that needs my attention. Now, also under circulation is CRT. We talk about capillary refill, because if I'm properly being perfused, then I'm going to have a great blanching, and it's going to come back within a second or two.
That's more useful with children than it is adults, right?
No, it's the same.
Well, I mean, yeah, adults will, but I mean, later or higher age, it's gonna be like 3 seconds sometimes.
Well, for older patients, yes, that's got chronic issues. And okay, I'll even say this, for the younger generation who's constantly smoking and their fingertips are already changing colors. Okay? So again, history taking is gonna be important. Well, you smoke. I mean, you'll know if they smoke, you can walk into the room and fucking kill. Okay? Just saying, whether that be,
Used to be in the letter, I know he smelled.
Yo, yeah. Smelled a lot of stuff, not even secondhand exposure to marijuana walking in the room, okay?
Smoke.
Fucking share? What?
I can already tell you fine. Go ahead.
Make sure to bring your medications into the ambulance.
Okay, so again, so CRT is going to be important. Skin color temp, we said. Turgor, Turgor is when you just kind of do the elastic and see how fast it kind of reacts and goes back to normal. Okay, that's not going to be the case with the elderly, because their skin is not as elastic as it used to be. It's very, kind of breaks down a lot easy. If you don't believe me, touch their skin and you just broke the skin and now it's bleeding. So, you know what I'm saying? So again, you have to pay attention to the actual population that you're dealing with. Now, the last thing under circulation that I'm teaching you is to obtain their blood pressure. So that now you have completed your primary assessment. 2, you have a set of baseline vitals, and 3, you can make the determination, well, is my patient, for my general impression, sick or not sick? Does my primary assessment confirm what I generally have thought? If not, that's okay. Just now you know you need to be aggressive with your patient in transport or treatment or both. Does this make sense? Does this kind of, okay? The monitoring devices that we carry, blood pressure cuff, again, please understand the rules to the blood pressure cuff. The bladder has got to go 2/3 around the upper arm of an individual. If not, you need to go up to the next one. And unfortunately, we don't carry a wide array. We either carry a pediatric one and a normal adult, and then maybe a large adult. On rare occasions, you'll have those ambulances. Well, I mean, I carried my own, but I had a thigh cuff. Sometimes I had to use those thigh cuffs on, yes, very fluffy. Okay? Just say it. Make sure that you're following the rules to a blood pressure and how to obtain a blood pressure. Now, we're going to go through this.
You got the light
I got a question. Is you using on
No.
that thigh?
Okay, because even the thigh cuff wasn't going to cover the thigh. Okay, so when you go into clinicals, you will be taking manual blood pressures. Those are the most accurate versus the ones that are
Do
automated.
we need our own?
I'm going to assign you.
No,
Okay, because a lot of the services don't even carry those anymore. They're so dependent on a piece of electronic that, yeah, no, not for y'all.
If I remember correctly, I mean, even if you miss size and go too small, you're gonna see a normally high blood pressure.
Just like if it's too big, it's extremely low. That's how come you have to understand the rules to blood pressure, just like the rules to suctioning, just like the rules to oxygenation and things like that. There's rules to everything.
If you wanna get the right pulse pressure and stuff like that, it has to be accurate.
It's got to be, okay? Now, if you take a manual blood pressure cuff and a couple of minutes later you use their automated and it's within 1 or 2, I'd give up to 5 on both sides, then you can use the automated at that point because it's relatively close to what you came up with. But we will not be using that as the initial set or the final set, okay? You are to, this is again, training your mind in order to listen to what you need to in order to obtain a blood pressure reading.
So,
Now, go ahead.
For baseline vitals, we're gonna go with the manual. For the secondary set, whether it's 5 minutes or 15 minutes in, we're gonna do both the automatic and another manual, just to verify, or are we just at that point going within the automatic?
If,
At the time, maybe just do it as a secondary.
yeah, well, definitely the initial needs to be manual.
Okay.
And then just document on your patient care. And normally, you know, with your blood pressure, just put M for manual and then A for automatic so that I know that when you document it.
What was it? I forget what it's called, but where you have the solid and then a slash and then P.
Palpated.
Okay.
So glucose check, is that the same way they do a diabetes check with your little strips and the blood?
Yeah.
I ain't gonna
Okay, so again, pulse ox reading, again, that is for, understand your equipment and how it works. The infrared light reads the protein hemoglobin that oxygen is being carried on. That does not,
It's not necessarily indicative of confusion.
correct.
And I'm guessing every ambulance is gonna have like a stockpile of nail polish remover nowadays.
Oh no,
How are you getting it off?
you're not.
I thought they, oh, what are we going then?
Trial shares.
Oh, God.
I know, like, no.
Okay.
So
The
when,
fingernails in the way,
I know, right? So when you have a lady or a man who's got nail polish on their fingers,
Yeah.
you're not gonna use that because you're not gonna get an accurate reading because it can't.
People who do that, yeah, so then what, are we just abandoning the whole?
No, you just give me a minute to spin
Oh,
it out.
sorry.
Okay.
Sorry. I'm excited.
The Pulse Ox comes with several different types of clips or sensors, if you will. The ones that we have are actually the one for the finger. There's actually a replacement that you can put on that is very flexible, and you can actually clip it on their ear. On a baby, it will go around their entire foot.
Okay.
So again, there's different sensors. Now, the one we have is not disposable, whereas the other ones are. And so the sensor will, go around, kind of use like Cubane and kind of self-adhere to itself. Those are disposable. You unplug it from yours and then take them into the hospital. That will plug into the machine there at the hospital. So there are different types of probes and sensors we use. But again, is this pertinent and relevant for me? Not necessarily. Because again, it is a diagnostic tool to help us, but it's not the sole thing of, wow, he's at 97%. He's fish breathing? I don't think so. See what I'm
It's a
saying?
backup, yeah. That was something we didn't
Again.
really deal with. We didn't have people using excessive nail polish and crazy nails or anything.
Yeah, well.
Or kids. Yeah. I was reading
Yeah.
it in this book, it was like, hey, you gotta remove that nail polish, so I'm guessing
Yeah,
you're not
no,
bothering
no.
with that, you're just going with.
Now, Grady, we used to carry like well, Grady didn't, but I did. I would actually go into the hospital and get nail polish removal wipes and stuff and use those. But again,
Maybe you
we
just don't have the time.
yeah, then they decided to get the regular probes that we can kind of strap to their ear and stuff.
So if they got like nail polish and they wear like ages, like those huge things, in that case, what do we do?
You're not gonna be able to use them.
Okay.
Yeah, at that
Yeah,
point,
at
at
that
that
point,
point, if you can't get it, you're not gonna get it.
So regular piercings are okay though.
It's just like
Yeah.
poke it to their nose.
Yeah, like the, what do you call those? Cages, thank you.
Yeah.
Yeah, you're not gonna be able to get that.
The young
Did you put it on their
generation.
toe?
These youths.
You can.
They're just out in these streets.
You can, but again, if they've done this, they've done those.
Yeah.
Petty middies, whatever you call it, I don't even know what you call it, what do you call it?
Yeah, but
Oh,
Petty
you
middies,
want
okay,
it.
whatever, I don't do that, so, okay. Alright, so, Pulse Ox, okay, so let me go back to the blood pressure cuff. So, when we start doing that in lab, I have a teaching stethoscope, in which I have a set of ears, you have a set of ears, they come together into one bell. So this is how you are going to learn how to listen for blood pressures, okay? Glucometer check or glucose check, that's for diabetics. It's not only for diabetics, but those are the ones that you see with the little kits. And so when we do an AccuCheck or a blood glucose check, we are checking for that nice range that everybody likes everybody to be in. I think your book says 70 to 110. I learned 80 to 120. So again, we want that in that nice range that everybody's so accustomed to seeing. Anything below that we need to fix. Anything above that y'all can't fix. Okay. Neither can paramedics to a degree. Okay, because we don't give insulin. All right. So glucometer check and cardiac monitor. That is something that it's not necessarily something that you are responsible for, but it is something that your advanced or paramedic will ask you to help him with in order to put on someone and so forth. And we'll kind of walk you through that process of what that looks like, or at least before we get anyway.
Yeah. So we're not gonna have to know the rhythms, but we're gonna be knowing proper placement.
Proper placement, yeah, just to assist your advanced and or paramedic.
They know all of it.
Mhm, yeah. Okay, so this is basically your primary assessment with your scene survey. And this is to get us started because again, because of the fact that we missed last week, we're trying to play a little bit of catch up, but at the same token, I want y'all to get your hands dirty and get accustomed to your equipment and carrying your equipment, being familiar with your stretcher, the operation, because that is the one tool you are going to use on every call as well as your jump bag. Now, for those of you that are physically fit, okay, I'm telling you, I am reiterating the fact that this is physically demanding. You are gonna know what that looks like when I bring Iron Man from the military, and you're gonna put him on that backboard and strap him to it, and y'all are gonna carry that from here to the end of that field out there and back, up and down that flight of stairs, so that you know exactly what you're getting yourself into. And you're gonna constantly lift that stretcher with him on it and back down, back up, put him in, take him out, back down, around. you're gonna go in all different places with Iron Man.
Me and my partner would like a respiratory aid present.
Heidi will be here, she's my respiratory therapist on call, so we'll have you hooked up.
If anyone needs to like train or something, I
Yeah,
think
those
those
carry bags with the O2 canister.
Okay, so-
Heavy.
So again, ladies, and I'm not trying to point us out, but let's face it, men are much more stronger than we are, so if you can't carry your weight, meaning you can't lift, you better be calling for backup. Don't even try to attempt it if you can't. Because you don't wanna be that person that gets your partner hurt,
Or drops the patient.
or drops the patient,
Or hurts yourself.
or hurt yourself. Because you will no longer be able to work in EMS with one back injury.
Kick you out.
Well, you be put on desk duty, that you be in the TMC.
Okay, so any questions over what we've gone over, because we're gonna kind of go outside and play a little bit with your equipment. And those of you that brought stethoscopes, that's great. For those of you who did not bring one of those little cheapy stethoscopes, I'm sorry. I'm in the process of ordering a couple of better ones to come in here, even though they're one or two, but still. Okay, so what I need for you to do, again, if you don't mind, take these tables and put them back up here so we can have this room to play as we go outside and bring patients in and out and all that fun stuff. Don't worry about leaving your stuff in here because I will lock the door. And only me and security have a key to this door, so
I seen that, I was gonna get it, but I was like, I don't need that yet.
what?
Oh, this is like replacement for all the old stuff, the lighting and stuff, we're gonna be running.
Let me
this
see.
to the fire
Let me see. Let me
station.
see.
Got all the neat stuff, I've added gloves and things, but you can go through all that.
Oh, cool.
I moved your stuff over here. Oh, thank you.
Oh, that's the one you brought on.
Yeah, for the fire station.
Yeah, that's what Amazon.
Sam's
What was
plan.
that?
That's what Amazon.
Yeah, Amazon has Lightning X bags, that's one of the small ones, then they have the massive like EMS and firefighter bags.
Man, you need to take your gloves out of the box and put them in a bag.
Yeah, I noticed that too, because it's taking up too much space in the back, and I need that for the BBM and the BP cup, the mask and all that. I separated and put it in a bag.
Yeah, no, that's the best way to do it. You need actually a whole array.
Well, that, there is in there, we took that out.
And I
Yeah,
I'm
That
not
is the
sure
one
yet.
that's
Yeah, that
primary.
was one we were
You didn't
using.
even
in the
make
fire
sure you
station.
keep your plate. Nails
Yeah,
not
that was
nothing.
my fault.
Nothing.
No.
Okay, this how it was. I had
Lightning
worked
X has it.
this weekend. That's why I been calling. I worked
Okay.
16-hour shift.
Nice.
Yeah, oh God.
Some of that stuff.
Oh, is this an
So-
Israeli
Yeah.
bandage? Yeah.
I got
love
one
these.
Blood
on
pressure,
the
yeah, some
other day.
with the clips and
You don't know what
everything.
Israeli bandages?
They
Oh,
make
here,
the
let me
good
show you
ones.
one.
You can, if you want,
At
it's like a
like
demonstration,
11
because I'll be replacing some of that weekend.
Not
Unless you
11.
have
I
one.
don't know, maybe a little bit up there. Yeah.
I have friends in low places too.
There we go. I'm on Amazon orders right now.
Amazon.
Amazon, not low
I've
places.
got so
And then I
much
had
on my
diamonds.
cart, it's not even funny. I've got like
You would-
13
yeah,
things that
you would
say.
I'm rocking 9 right now.
I'm not gonna lie,
Okay,
it's like
so
30.
once we get into trauma, you'll kind of learn this. But anyway, the Israeli bandage comes in either 4-inch or 6-inch, sometimes even greater. So these are like sucked down and so forth. So whenever I was teaching the combat lifesaver trainer at Fort Benning, so this is what we used was the Israeli bandages.
Yeah,
And so
still the same color too.
yeah, no, right? It's great. Okay, so it comes like suction down in order to cut the money.
Sterile and stuff, 'cause you know if it's inflated, the air got it, it might not be sterile.
Thank you. Okay. Wow, this has been wonderful. So anyway, so once you open it up, right? You're supposed to not touch things because again, this is for an abdominal wound. This goes up against the patient. Okay? So this is an abdominal wound, chest wound type of thing, right? And it's already got your your wraparound. Now, the thing about this is, let's say this is a smaller edition, I can use this as a pressure dressing in which once I wrap, right, borrow your arm. So if I'm doing his arm, and let's say I don't have enough pressure and I actually wanna put pressure on that spot, I take this and go through the bar, which again, this is so huge. I take it through the bar and come back on it. And then where this is applying pressure is gonna be over the spot that I want pressure. And then you wrap this way.
Okay, and
So-
then how do you end up clamping it down then?
It's got Velcro at the end.
Okay.
Yep, and it Velcro's on
This thing's
itself.
amazing.
Yeah, these things are great. Love these.
How much are they?
Cheap, actually.
Yeah,
Well,
I don't
know.
depends on when you
I
get it,
tried
but surplus, you find that stuff pretty cheap.
Yeah, so Israeli bandages are great, because back in the day, when, I'm not trying to be funny, soldiers in World War I and World War II, Korean War, Vietnam War and stuff, the only thing they had was like this little bitty piece of gauze about this big that had wings on it. So if you got shot with a bullet hole, you know, that was enough for a bullet hole, but if you got shot more than once, you're screwed.
Yeah.
So, yeah, they were small like this. So I have several of those at home. I'll come bring and show you and stuff. But they're great for like single, but you know.
There's nothing stopping you from putting an extra set of gauze. Like for entry, go into the small set and then use the big patch for the actual pressure is the exit.
Okay, so pull out your stretcher, grab your jump bag, your O2 kit, or your O2 bag.